Now we are going to start our lecture about EUS guided gastroenterostomy with our great professor Hakan Senturk from Turkey.
Okay, I think you now see the screen, no problem?
Yes, very clear.
Very clear, okay. Actually, we encountered very important obstacles, but finally we overcame this. But today I have had a very stressful day in my endoscopy unit, but after meeting so many lovely brothers from Egypt, I now feel very relaxed and happy. So these problems did not affect me badly. Now I am going to start to discuss the issue of EUS guided gastroenterostomy. EUS guided gastroenterostomy actually is an emerging technique. This is not a very well established technique like the others, hepaticogastrostomy, cholecystectomy, radiofrequency, and all the others. And it is largely restricted to some expert centers at the present time. First of all, I am going to summarize the existing methods for performing gastroenterostomy. In the freehand technique, an linear echoendoscope is inserted into the stomach. Then from stomach, we identify an jejunal loop close to corpus of the stomach. But in this process, we try not to confuse transverse colon with jejunal loop. It is very easy. If you inject some contrast, you can easily differentiate between duodenum, jejunum, or colon. And after inserting a 22 gauge needle, we inject a liquid containing water, contrast material, and some methylene blue. And after injecting this contrast, we confirm that this is a jejunal loop. And afterwards, we withdraw the 22 gauge needle, and this time we insert a 19 gauge needle, because 19 gauge needle is accepting point of 35 guide wire, which is necessary for this procedure. And with 19 gauge needle, we easily identify the distended loop, and we insert the needle into this loop. And with syringe, we confirm that we are in the desired loop. And afterwards, we pull the stylet, we withdraw the stylet, and we insert a 0.035 guide wire, preferably a rigid guide wire, into the jejunum. And then we, through the guide wire, if we have the hot axios stent, that would be a very easy procedure, because we insert the hot axios. It has an electro tip, and we dilate the stomach wall as well as jejunum, and we insert the distal flange of hot axios into the jejunum, and then we deploy it as it is instructed. But the problem with the hot axios stent is that it is very expensive at the present time. In Turkey, its running price is €4,000, and because of this, we are looking for some alternative routes. Another approach is that first an guide wire is inserted into the third part of the duodenum and jejunum, and then the gastroscope or enteroscope is withdrawn, and over the guide wire, an dilation balloon is inserted into the third part of duodenum or jejunum. And the balloon is inflated, again with fluid containing contrast, water, and methylene blue. Then this balloon is identified, and it is again punctured with a 19 gauge needle. But this technique is not a very good technique. I am going to say that I encountered some problems with this technique, because after inserting the guide wire through the balloon, the guide wire may be entangled. And furthermore, over the guide wire, when you try electrocautery to dilate the tract, if you electrocautery the balloon as well, it would be stick to the balloon. We encountered this problem, and because of this, I do not advise this technique. Another technique we frequently use is that we insert an double balloon enteroscope, and through the stricture, when we are stuck to the stricture with enteroscope, we insert a guide wire into the duodenum, into the third part of duodenum. Then we withdraw the enteroscope. However, we leave the overtube here. So we insert the enteroscope. The overtube is present over the enteroscope. And then we withdraw the enteroscope and the overtube remains here. Because if we do not put an overtube here, the guide wire will have a large space here, and over the guide wire to insert the balloon is impossible. So if you are going to try this technique, what you should do is that you insert an enteroscope with overtube, then you withdraw the after guide wire insertion, you withdraw the enteroscope and you leave the overtube in its place. Then you put a double balloon over the guide wire into the duodenum and jejunum. And I am going to show the videos. And then you inject contrast sequentially into the two balloons. And finally, the space between the balloons. So this balloon is a prototype. I use the balloon from Microtech. There are three openings. The first is in the distal balloon, the second is in the proximal balloon, and the third is in the between. After injecting contrast with water and methylene blue in this space, we puncture this closed loop. The advantage here is that because this is a closed loop and you fix it with these balloons, the problem of missing the jejunum and causing a free perforation is less with this technique. However, even if you inflate this balloon properly, you cannot guarantee that they will remain in their place. So in the procedure, even if these are inflated, sometimes they would go forward and back, and it would still be a problem. Another technique is that you insert a guide wire through the 19-gauge needle into the jejunum, and you try to push it to the stricture from the third part of the duodenum or jejunum. Then you grasp this with a biopsy forceps, and then you get it from the mouth. So you have both the proximal and distal end of guide wire in your in a secure position. Then you can insert the any type of stent easily. But the problem is that grasping the guide wire from this route is very difficult. I tried it, but I cannot manage. Furthermore, even if you get this wire out and you puncture with EUS device from here, still you can push the jejunum. So even if the guide wire is withdrawn from the mouth and you perform the procedure over the guide wire here, it is not enough secure, because when you push the stent, you can still invaginate the intestinal loop. Because of this, another technique was suggested that you grasp the guide wire here and you insert a forward viewing scope such as an enteroscope, and you put the stent from the jejunum. But the problem is that because there is a stricture here, it is difficult. So at the present time, this technique and this technique are the preferred ones. I largely used this double balloon technique. This is the room. Most of our Egyptian friends are very familiar with our endoscopy room. It is a room with every facility are present. And these are the accessories we use. This is a 19 gauge needle from Microtech Company, jag wire, 6 French cystotome, the prototype double balloon from Microtech Company, Axios stent, we do not use very frequently, and the cystogastrostomy stent from Microtech Company. Actually, the price of this stent is 1/10 of this Axios stent in Turkey. So this is like 400 euro. This is 4,000 euro. This is 400 euro. Because of this, we have no other way but to use stents rather than Axios stent. We only use Axios stents in workshops. You remember in recent Asia Pacific workshop in Istanbul, we performed Axios stent for 2 patients with pancreatic cyst drainage, but these were provided free of charge. So if you have enough support, then you can use this, but otherwise you should use other types of stents. What about the hitherto data about endoscopic ultrasound guided gastroenteric anastomosis? This is a meta-analysis, and you see that even in this meta-analysis, it complied most of the data present. The number of cases are not too much. And technical success rate in this group, you see 15, 18, even 7, and the largest one with 74 patients. The success rate, technical success rate is very, very high. But you should take into account that these are expert centers. So these cannot be duplicated in real life data. The problem with gastroenterostomy, EUS guided gastroenterostomy, is that we are having only data from expert centers. We do not have some real life results. Technical success rate is very high, but not only technical success, as you are going to see, clinical success rate is very high as well. And in these studies included in this meta-analysis, you see in more than half of the patients, they use the direct puncture technique. In some of the patients, single balloon, but no other type of, you see in this meta-analysis, there has not been any study using double balloon, because as I said, this is prototype. It is not present in market. You can only obtain it from the company with some personal relations. And in most of the experts use other hot Axios or cold Axios stent, but there are some other stents as well. Technical success, as I said, over 90%. Clinical success is over 80%, so perfect results. And adverse events rates are exceedingly low. In the first studies, some cohort studies, it was found that the adverse events rate is more than 20%. But as you see, in these studies, the adverse events rates is very low. Of course, we believe that it happens, but I am going to say that if you are doing in your center, you encounter too many complications, even some fatalities. In this study, the fatality rate is less than 1%. But as I said, these data should be reviewed with caution, because in real life, this is not what is happening. This patient presented with the obstruction of the afferent loop of B-rod 2 anastomosis. Actually, this was a patient operated on for a malignancy, and a B-rod anastomosis was performed. But after birth anastomosis, the tumor recurrence happened and it obstructed the afferent loop. And because of the obstruction of the afferent loop, this patient developed not only severe pain, but jaundice, because there was no drainage of the afferent loop. In this patient, we punctured the afferent loop with a 19-gauge needle, put a guide wire, dilated the tract with 6 French cystotomy, and then we put a fully covered metallic stent. So you see that in case you cannot approach the papilla by ERCP, if you are able to insert a stent into the afferent loop from stomach, then you can also perform ERCP from this route as well. In this patient, we did not need to insert a gastroscope because the problem was the obstruction of the afferent loop, not the bile duct. But in case, this technique can be used for this purpose as well. This is another patient with Roux loop syndrome. This was a patient who was operated on for a malignancy as well, and the Roux-en-Y anastomosis was performed. But afterwards, because of the tumor recurrence, Roux loop was obstructed this time. We identified the Roux loop from stomach here. And again, we inserted a 19-gauge needle, all the same technique, and we put a metallic stent. And you know very well that in Roux-en-Y anastomosis, performing ERCP with usual route is not possible. So in this patient, in addition to hepaticogastrostomy, you can also put a large metal lumen opposing stent. Then you can go through the stent into the Roux loop with a gastroscope, and you would perform ERCP. And this technique is also applicable to the patients who had an operation for obesity, like Roux-en-Y anastomosis. So a large part of stomach is excluded. In these patients with the usual route, you cannot access to the papilla vateri. In these patients, like in Roux loop or afferent loop, you put a stent from the remnant stomach, and then you enter this part with a duodenoscope, then you can perform the ERCP. But in this case, the lumen opposing stent should be at least 16 millimeter in order to have the ease of insertion and maneuver of duodenoscope. This is a patient with an gastric outlet obstruction due to pancreatic carcinoma. We identified a jejunal loop from stomach. We inserted the 19-gauge needle between the balloons. You see, 2 balloons. And we punctured the in-between space. We negotiated the stent opening, and the opening is complete. So methylene blue is draining out. The gastrojejunostomy is successful. This is another patient We inserted the balloon, double balloon with an enteroscope. We identified the jejunum. Again, 19 gauge needle. And the stent is deployed. Interestingly, after 2 weeks, I returned and I withdrawn the stent. And I enlarged this area with 20 millimeter balloon only after 2 weeks. So in 2 weeks, the anastomosis was already complete. I dilated the tract with 20 millimeter balloon, and you see I can go easily from stomach into the jejunum, the 20 millimeter balloon. So you can even perform it after 2 weeks. It was very interesting. I expected that the anastomosis, the fistula needs to develop after at least 4 weeks, but after 2 weeks, it's okay. In another patient, after 3 weeks, I returned and I performed balloon dilation with 20 millimeter again, but at that time, a perforation happened, a very large perforation. But I put an fully covered through the scope esophageal stent, and no problem happened, and the patient recovered well. Finally, I am going to show you another interesting patient. The patient presented with pancreatic carcinoma. The patient has jaundice, but at the same time, there was gastric outlet obstruction. In this patient, I could not went through the gastric outlet obstruction even with the guide wire. It was completely obstructed. So I first performed an hepaticogastrostomy. And then after hepaticogastrostomy, I put a guide wire through the hepaticogastrostomy and papilla vateri into the third part of duodenum. And I, you see the distal common bile duct and jejunum. And over the guide wire, I inserted a balloon into the duodenum, a stone extraction balloon, and I injected contrast into the jejunum. Then I identified this jejunal loop with a linear EUS scope. And I also performed gastrojejunostomy. So in one session, both hepaticogastrostomy and gastrojejunostomy, and even if it is totally obstructed, so this is a possibility. And you see, after the procedure, peritoneal carcinomatosis is also present. Hepaticogastrostomy stent here, and gastrojejunostomy stent. This is hepaticogastrostomy, and this is gastrojejunostomy stents. As a conclusion, EUS-guided gastrointestinal anastomosis is yet to reach prime time. It is restricted to expert centers. According to a very recent study, it was proposed that for proficiency, one should perform 25 cases, and for mastering, one should perform over 40 cases. We are yet to have real-life results that will reveal different results that was found in expert centers. And self-expandable metallic stent may be much more cost-effective than single-action lamps. So for this patient, we should consider, instead of lamps, for example, 20 millimeter fully covered esophageal or colonic or enteral stents. However, on the bottom line, gastrojejunal EUS guided anastomosis seems the way to go. Thank you very much.
Thank you very much, Professor Hakan, for such illustrative and informative lecture. It really seems to be a very hard technique and needs many times of training. Actually, I have 3 questions. Would you give me the permission, sir?
Yes, please do so. Thank you.
First, what is the advantage of EUS gastroenterostomy over the traditional method of duodenal stenting by the gastroscope?
Okay,
the best
I can answer question by question if you let me. Actually, this subject was the subject of many studies. I mean, not many, but a few studies, and they compared the duodenal stent to gastrojejunostomy. But of course, these studies were not very large, and their conclusion was that the stent migration, bleeding, occlusion, stent failure was very common, and in comparison to that, gastrojejunal anastomosis is having better long-term results and even less complication. And actually, in our own experience, the same is true as well, because, for example, for biliary stents, esophageal stent, it is better. The outcome is better, but for duodenal stent, the migration rate and occlusion rate is very high. So the idea is that gastrojejunostomy is better in comparison to duodenal stenting. But of course, as you said, it is a cumbersome technique.
Okay, sir. The second question regarding the direct method in which we use the echo and scope only, how can I identify the jejunum accurately? So I puncture it, and you mentioned, sir, that we puncture with a 22 gauge needle, then we replace it by a 19 gauge. Why don't we puncture by a 19 gauge needle from the start?
Yes, very good question. For 2 reasons, because 22 gauge needle is less traumatic, so you can repeat it from several sites. We do not want to puncture intestine from too many sites. That is one of the reasons. And the other reason is that you see these 19 gauge needles, if they are used for more than 2 times, their efficacy is decreasing. So sometimes pushing the guide wire and maneuvering the needle may be difficult after some experiments. Because of this, I prefer first to use 22 gauge needle, then go on with 19 gauge needle. But of course, this is a paradigm. So you can start with 19 gauge needle as well. In identifying the jejunal loop, when you are in the corpus of the stomach, and when you maneuver the scope clockwise and counterclockwise, you would eventually find some jejunal loops. It is 100%, so you can find it anywhere.
Mostly when I do okay, go.
But the problem is that sometimes, rarely, it didn't happen to me, you can confuse jejunal loops with transverse colon. That may be a problem. But after injecting contrast, you can easily differentiate Hofstra of colon from jejunum.
The most proper site is at the greater curvature by doing
Greater
anti-clockwise
curvature.
in the.
Yes, greater curvature. I mean, just in the middle of corpus at greater curvature. That is the best place. But sometimes, you see, while performing the procedure, we do not pay too much attention to endoscopic view. And once I put stent from just 2 centimeters distal to cardia. That is not a place which is preferred, but anyway, it worked. So in most of the time, because we are focusing on the endosonographic image, sometimes we cannot choose the best site of stomach for puncture.
And after puncturing, we use system 6 French. Then no dilatation, no balloon dilatation. We use
yes,
dilatation.
Yes. Six French cystotom is enough, but sometimes we use 5 to 10 Bucci dilator. But later, what I found was that it was not actually necessary, because 6 French cystotom is providing enough space for the insertion of fully covered metallic stent. But here there is a trick which is very important, that you should try to go through the stomach wall, and especially from the intestinal wall, with a very brisk push. So if you go slowly, it is certain that you are going to push the intestinal wall. No problem with gastric wall. You can puncture the gastric wall anyway. But after you are in peritoneum and you are trying to puncture electrocautery, with electrocautery, the intestinal wall, you should go very rapidly, very briskly. Otherwise, if you go slowly, you cannot enter the intestine. You push it, or you can cause invagination. So this is a very important moment. But here you should try to do overshoot. If you do an overshoot, you go from one side of intestine and you are out from the other side of intestine. It happens. In some workshops previously, I have seen this. They went into the jejunum and they go out. And when they put the stent, the stent traversed the jejunum, and it was in peritoneum, so pre-perforation. It happens. So it requires a great deal of command, not only in endoscope, but in the accessories as well.
Of course, sir. There is a question from the audience. What is the ideal time to remove the stent after the procedure?
Actually, after 4 weeks, a fistula develops between stomach and intestine. I think the same is true for hepaticogastrostomy and choledochoduodonostomy as well. Actually, I wanted to ask this question to Dr. Giovannini, but I couldn't have connection. So for gastroenterostomy, what I suggest is that after 4 weeks, you can withdraw the stent, you dilate the tract with 20 millimeter balloon, and it will go open for the lifetime of the patient, which is not very long. That is my advice. But actually, it is not very well established. You cannot find a solid answer to this question. In general, they say that you leave the stent there. But I think having a permanent fistula may be better, because why? Because you see that from cystogastrostomy, we have an experience that if you leave the lumen opposing stent for more than 4 weeks, the risk of bleeding is increasing. The same may happen in gastrojejunal area as well. And as I showed you, even after 2 weeks, interestingly, fistula developed. So this is an area which has not been scrutinized. Nobody paid too much attention to this. They put the stent, or we put the stent, and we leave it. But it seems that in most of the time, a fistula is opening there, and because the natural route is closed, so the fistula will not be closed.
Another question. After EUS gastroenterostomy procedure, when to do ERCP? Shall we wait until tract forms to hold lambs off, or we can do it immediately after inserting lambs?
Actually, in general, the lamps is put, and some at least 48 hours is left between two procedures, because the stent should be very well placed there, because they are expanding. But if you do not want to perform a second procedure, you can do it in the same session. But what I suggest is that you leave at least 48 hours, because the problem is that if you immediately insert the duodenoscope, especially, so for Roux-en-Y, duodenoscope is not necessary. You can do it with gastroscope. If you put a duodenoscope through the lumen opposing stent, you can migrate it easily. So at least 48 hours should be left between the placement of lamps and further ERCP.
And of course, if it is self-expandable metallic stent, the possibility of migration is more and more than lumen opposing metallic stent.
Of course, and but even lumen opposing stent is not 100% secure for migration. It even happens with these ones.
Do we use fully covered SIMS or partially covered?
In general, I use partially covered with large flanges from Hisa. Hisa is a Korean company, and they are producing such stent with very large flanges. These are not fully covered, semi-covered stents. These are perfect. Sometimes, if I put fully covered stent, I put some clips. You may see it in the video.
Fix it.
Fix it, yes. Sometimes I put some clips as well. But the problem is that even if you put clip to the stomach side, the jejunal part may flip. Because of this, large flanges are necessary. And another interesting point is that in some patients, while we are trying to put the stent migrated from the stomach into the peritoneum. And in one of these patients, actually I put a stent first through the stomach into the jejunum, and because it migrated, I kept the guide wire and I put another metallic stent through the first one. It appeared to be successful, but afterwards, the distal part of the stents dislodged from jejunum. And I withdrawn the first stent, but the second stent did not come out with it. And because of this, from the large opening from the stomach, I inserted a grasper forceps. I grasped the stent in the peritoneum, and I withdrew it from the peritoneum. Afterwards, so there was a very large opening. I returned with gastroscope to close the space, but interestingly, it was already closed in 5 minutes. So stomach is such a forgiving organ. And I filled the stomach with water and contrast, and there was no leak. So I think for beginners, that would be a point for not to be very worried about the results. So even if you insert a large stent through the stomach, peritoneum, it is in peritoneum, you withdraw it, and stomach wall is spontaneously closed. That's a good point. But of course, it
It's
does not mean that.
muscular wall.
Sorry?
The opening will close because of the muscular wall of the stomach.
Yeah. So it is, stomach is a very forgiving organ.
Is there any distance should be present between the stomach and the jejunum before when we are examining by EUS before puncturing? Like in cystogastrostomy, the distance shouldn't exceed 1 centimeter. In gastroenterostomy, also there should be a certain limit of distance between the stomach and the jejunum.
Unfortunately, there is no established limit. And you see that this is something dynamic, not like cystic, I mean pancreatic cyst.
Yes,
because if you push the intestine, the distance may be very large. And there is no established distance. But what I am going to say is that while starting, if the distance is more than 2 centimeters, it is very difficult. But as I told, when you inject a large volume of fluid containing contrast and water, we inject sometimes up to 500 milliliter fluid, then it will be close to the stomach because of the distension. But this distension is not keeping its place for a long time. It is very distended, but after some minutes, it will be washed out.
Thank you very much, our professor, for your patience and your great illustrations and for such elegant lecture.
Thank you very much.
Is there any other questions from the panel?
Yes, I think there is a question missed here. What is double balloon? Is it from Microtech only, or?
Oh yes.
Evangelos Voudoukas. Yes.
Actually, I didn't understand this question.
How can someone get the double balloon catheter in his or her unit? Is Microtech the only available catheter company?
No, it is also produced by Olympus Company, as far as I know, but it is also prototype. So actually, Microtech Company is a more friendly company, because I asked it for Olympus and they didn't provide it. In most of the time, these companies are not sending these prototypes to countries other than they are labeled as investigative. For example, in Europe, some European countries and United States, they provide it to some centers. But we could only obtain it from Microtech Company. But of course, they were also somehow lukewarm while providing. In the first instance, they said this is prototype. We cannot let it use outside of China. But with some personal relations, I obtained it. But you see that this catheter is not approved for use in this country. I think it is the same for your country as well. But I don't think it would be a reason for some medical legal problems. Actually, if you want to perform it in Egypt, you would say, I would refer the Microtech guys to you, and they would give you some double balloons as a gift.
One thing I'll add from our experience here in the U.S., the earlier question about duodenal stent versus gastrojejunostomy. If you recall, the original studies comparing surgical gastrojejunostomy with duodenal stent, the idea was if the patient's estimated survival was more than 6 months, the gastrojejunostomy was favored. And I think that same idea applies here. We're finding, with advances in chemotherapy, many of these patients now survive greater than 6 months from their time of their diagnosis. And we see a lot of stent occlusion, duodenal stent occlusion, and so on. We also see that these patients seem to develop a type of almost gastroparesis independent of the obstruction. And so I think there's a lot of benefit to upfront gastrojejunostomy through EUS based on the same principles that we knew from before. And the second is just a technical thing we do to keep the jejunal loop dilated. We just hook the foot pump, your irrigation pump, to a nasocystic or a nasojejunal tube. And then if you're able to pass that beyond, in real time, you just instill the water while you're watching under EUS, and you see it kind of grow in front of you, and then you go for your puncture. So lots of different ways to do that. Thank you. Terrific talk.
Yes, yes.
Actually, you see, your point should be very well taken, because in most of the studies, it was revealed that surgical gastrojejunostomy is working well and longer than duodenal stents. So if now we are doing it with EUS, so it is perfect. And most of the surgeons now are for this technique. So they do not want to perform surgery for these patients. But the problem is that because they do not know this technique very well, in most of the time I ask them whether they want me to perform a duodenal stent or gastrojejunal EUS guided anastomosis. I am going to say more than 2/3 of the surgeons, in more than 2/3 of the time, they say duodenal stent is okay. That is the technique we know. So if you cause some peritonitis, this patient will die, and you go on with duodenal stent. Is it the same in your country?
We just don't ask the surgeons what they think.
But at the end of the day, if something untoward happens, so yes, we must call surgeons.
No, you're right, but you described very nicely, how to manage the complications. That's the other thing, as we get more comfortable with some of these, intentional perforations and these things. I think even when there is a complication, we've become a lot more comfortable of not reflexively asking a surgeon to come fix it. So, and you're right, that is always a negotiation that has to be made, for sure.
Yeah, and I want to add to what Dr. Patel is saying, that it's always like a battle for us, because Dr. Patel and I work together. It's about convincing them. So initially, they were very skeptical when we started doing gastroj.
So we should be as convincing as Donald Trump.
Yes, but the easiest way to convince them is to start with high-risk, non-surgical patient that they don't want to do. And then once we do that, and then oncologists accept the result, then the technique becomes standard of care. We're still in this phase right now. We try not to, if they want to take the patient for surgical gastroj, we let them, but we try as much as we can to do it by endoscopy. But I think once they get used to us doing it and it become accepted, it will be an endoscopic procedure.
Mm-hmm. And I know Dr. Othman, he saved a patient with afferent limb syndrome, and the surgeons had very limited options, and he very nicely recovered that patient. And I think that, went a long way in our institution for gaining support as well.
Okay, thank you very much for this very nice debate and this very difficult subject.